So without further ado, it is my absolute pleasure to introduce our first speaker, Dr. Daniel Bodri, who is a clinician from Alicante in Spain. And his talk is entitled Regenerative Endometrial PRGF, Plasma-Rich in Growth Factors Treatment in Patients with Thin Endometrium, Recurrent Implantation Failure, and Recurrent Miscarriages, a retrospective self-controlled cohort study. Dr. Bodri, the floor is yours.
Dear Chairperson, dear ladies and gentlemen, thank you very much. It's a great pleasure to introduce our experience in endometrial PRGF, plasma-rich in growth factor treatment from Alicante, Spain. I have no conflict of interest to declare. Adequate endometrial thickness and receptive endometrium are essential for a successful pregnancy in ART cycles. Thin endometrium is usually defined as less than 7 millimeters, and it is associated with low embryo implantation rates. The etiologies could be multiple, or it could be also idiopathic. And another clinical conundrum is the recurrent implantation failure. The definition of RIF was recently revised by the ESHRE working group, and instead of focusing on a fixed number of failed embryo transfers, it was recommended to evaluate the cumulative chances of conception for an individual patient. If a patient does not get pregnant after reaching a RIF threshold of above 60%, then the case is labeled as recurrent implantation failure, and investigations or treatments could be warranted. For both of these conditions, several treatment approaches have been proposed with more or less success, including the recent applications of regenerative medicine using PRP or other substances. PRGF is a subset of PRP, and it is obtained by concentrating the platelets from the patient's own blood by increasing the platelet count to 2 to 10 times of the normal concentration. It is thought to include bioactive substances, and PRGF has been shown to induce tissue regeneration and could also have immune modulatory characteristics. PRP was first used in heart surgery and sports medicine many decades ago, but since its use has been extended to other fields of medicine, it is used to regenerate skin and cartilage for wound care. It is also used in ophthalmology to treat dry eye, and even used in aesthetic medicine, for example, for hair loss. In the field of reproductive medicine, you can see here a list of first publications that started some 6-7 years ago, and PRP was used in preimplantation ovarian failure, or sorry, premature ovarian failure, diminished ovarian reserve, for thin endometrial lining, or recurrent implantation failure, and even more recently for the male in cases of non-obstructive azoospermia. At this year's ESHRE, I've counted up to 12 abstracts, including regenerative medicine, mainly PRP or some other substances too, mainly with the indication of endometrium or ovary, and we have the pleasure to, I hope you have the pleasure to see 2 topics today on PRP. So we have conducted in our single private art center, actually it's a headquarters of a group of 3 Spanish clinics in Alicante, this study on endometrial PRGF treatment. Actually, it was started in 2016, much before the whole PRP sort of treatment started in other Spanish clinics. We have obtained an external ethics committee approval, and now we are presenting our experience using a retrospective self-controlled cohort study design involving 108 patients who have undergone over 150 PRGF endometrial treatments that resulted in 132 embryo transfers. As a control group, we have used the previous, mostly failed embryo transfer cycles of the same patient group, and this amounted to 229 previous embryo transfers. Actually, we only included the cycles performed at our center, so these patients could have even have more failed cycles than this number. So here are the participants and the main indications. The main indication obviously was thin endometrium, which was defined as an embryo transfer in a previous attempt or a cancel cycle where the lining did not reach 7 millimeters. 65 patients were included with different etiologies, Asherman syndrome, different grades, mostly operated or even multi-operated, previous uterine surgery, premature ovarian failure patients, or simply refractory endometrium without any obvious cause. The second group was recurrent implantation failure patients, 36. These patients had at least 2 or 3 previous failed embryo transfers. Most of these patients, of course, were egg donation patients, or if they were using own eggs, then it was by euploid embryos. But these patients didn't have any issues with their lining. And the third group was a smaller group of 7 patients who had recurrent miscarriages. You can see here the mean age, and some of the patients had secondary infertility, so some of the patients had maybe a previous success, but then in subsequent cycles for the second child were not successful. Our PRGF was prepared by drawing the patient's own blood, approximately 30 milliliters, and then concentrating it by centrifugation in using a in-house method. And we have obtained approximately 5-6 milliliters of this PRGF fraction, which was activated and then frozen for subsequent use during the endometrial preparation. Here you can see the treatment protocol. We had basically 2 approaches. One approach was a quite innovative approach using a hysteroscopic subendometrial infiltration at the beginning of the endometrial preparation, practically on day 4-5, just at the end of a period bleeding. This hysteroscopy was done with a diagnostic rigid hysteroscope under sedation and under visual control, using an oocyte retrieval needle. Small amounts of PRGF were injected below the lining on several spots. The patient continued her endometrial preparation using an HRT prepared cycle by a high dose of oral vaginal estrogens. And then later during her preparation, 3 more intrauterine instillations were done around day 8, 10, and 12, every 2 days. And of course, each time the endometrium was evaluated, you can see the video. And if the endometrium was judged sufficient, then progesterone was started and the patient have undergone frozen embryo replacement, involving usually a single embryo coming from egg donation or maybe a euploid embryo if doing own eggs. So this was the first approach. The second approach was simply doing the intrauterine instillations, a simpler approach, and skipping the hysteroscopic part. So here you can see the reproductive outcome for the 3 subgroups. In the thin endometrial lining group involving 65 patients, we have performed 99 treatment cycles. Some of the cycles, 16%, were canceled because the lining did not reach thickness that was judged sufficient. So this resulted in 83 embryo transfers in the PRGF group. As a control group, we have looked at 113 previous embryo transfers. Most of them failed. So here you can see the reproductive outcome with ongoing pregnancy/live birth rate. We have obtained 24% in the PRGF group versus 4.4%, which is very low in the previous control cycles. So it is definitely a clinical difference. As you can see, approximately half of the interventions were done with the combined hysteroscopic and instillation approach, and the other half using only instillations. The second subgroup of recurrent implantation failure patients, it was 36 patients undergoing 42 treatments. Here the cancellation rate was much lower, so we have managed to do 39 embryo transfers. you can acknowledge that in the control group, we have a very high number of previous failed cycles, 101 embryo transfers, practically almost 3 times as much as in the experimental arm. And the success rates with ongoing / live birth rate were 36%, which is very good in the experimental arm, and 7.9% in the previous control cycles. And approximately 2/3 of the interventions were done with the hysteroscopic approach or the combined approach, and the other 36% with installations only. And the third group, which was of course less numerous, only 7 patients, recurrent miscarriage group. Initial results were encouraging in terms of positive pregnancy rate, but it seems that after the first trimester, it seems that PRGF did not prevent these patients from miscarrying, so we did not obtain any ongoing pregnancy. We also have some basic maternal-fetal outcome results. There were 2 late miscarriages for different reasons. Some pregnancies, of course, are ongoing, but we had 23 deliveries so far, resulting in a healthy, completely healthy offspring. Of course, except one case, all of them were singletons. And as expected in this mainly egg donation group, we had a high rate of C-section, some premature deliveries too. And we have observed 3 placental complications, 1 case of placental previa, and 2 manual placenta removals after delivery. So, in conclusion, this preliminary retrospective study showed encouraging results, especially in the thin endometrium and RIF groups. The source of PRGF is patient's own blood. It's considered to be safe and relatively affordable. Of course, randomized control studies are warranted, but such studies are difficult to design because in these indications, the groups are pretty heterogeneous. And of course, given the lack of any efficient treatment in the non-treatment arm, it would be difficult to persuade the patients to do a randomized study where they might not have any result and risk to have a very low pregnancy rate. Further, in the future, the PRGF preparation, of course, could be standardized further. In-house versus commercial kits could be compared. And the treatment protocol for endometrial PRGF could be also tailored. The need for hysteroscopic infiltrations or the number of timing of installations could be also further investigated. Thank you very much for your attention.
Thank you very much for your presentation. Are there any questions from the audience? Please use the microphones.
Thank you very much, Natalie from London. I see now the hysteroscopic obviously is better. I can see according to results. Have you changed or altered? What are you now currently doing, having seen your results?
I mean, the study maybe was not powered to compare the 2 approaches. It seemed maybe that in the thin endometrium group, I mean, just by looking at the number of pregnancies in each group, maybe the hysteroscopic version was a little bit better for the thin endometrium group. And there were a little bit more pregnancies in the recurrent implantation failure group using the installation approach only. But this was not the aim of the study to check. I mean, most of these patients, of course, had hysteroscopy, so their uterine cavity was evaluated. Probably in larger studies, we could investigate it further.
Well, you said you were doing multiple hysteroscopic installations, so...
We had the initial hysteroscopy at the beginning, and then the installations were not hysteroscopy. It was just like in the consultation room, a very simple procedure like an insemination. We did it under ultrasound guidance, but it's not a must. I mean, we would, of course, evaluate the lining, even like 3D scan, and vocal was sometimes performed. So ultrasound has an important role. Yeah.
Hi, very good presentation. Congratulations. My question is, what's the volume of the PRP that you used?
It was a small volume, so basically from one PRGF, like aliquota of maybe 5-6 milliliters, it was enough to do, if necessary, both the hysteroscopy and the installation treatments, because it was like frozen. I mean, and thawed when necessary for the, like maybe 1 milliliter or so was instillated or flushed into the uterine cavity, not so much as it would come out.
Thank
yeah.
you.
Thank you.
Thank you for your presentation. I'm wondering if you have any, if you have followed these patients, if you know if they suffer from preeclampsia, severe preeclampsia, or mild preeclampsia.
I mean, these were mostly ag-donation pregnancies, so preeclampsia is expected to occur like even up to 20-25% of the cases. In these 23 patients that we had, well, we had some of these complications. Some of them might have had preeclampsia, but it was not higher than expected, like in ag-donation pregnancies. So at least the offspring was healthy. I mean, there were some premature deliveries, but like it also happens in ag-donation pregnancies. So.
Thank you.
Thank you very much. I'm afraid that we are running out of time. Could you please approach Daniel afterwards, because we would need to go forward to the next presentation. I do hope that this is okay.